welcome to Grand Rounds. It is, I believe it'll be our last one for the year. Next week will be a holiday. And I'm Lisa Dixon, and I have the pleasure of introducing Dr. Colleen Berry, who is the second recipient of the Essock Award Lecture. So I'm going to talk a little bit about the award, and then I'm going to introduce Dr. Berry. Dr. Susan Essock is a retired member of our faculty, professor, and the first director of the Division of Mental Health Services and Policy Research. And Dr. Essock is here somewhere in the audience. Dr. Essock's career emphasized facilitating the translation of research findings into mental health policy and practice, addressing problems faced by mental health administrators and evaluating the impact of behavioral health services delivered in routine practice settings. Her grants, papers, awards, activities, of which there were many, shared the theme of service and government service and rigorous research. Susan was always, how does this matter? What does better look like? Is your work making a difference? A common theme in her research has been creating scalable ways to implement new services, monitor implementation fidelity, and anybody who spent any time with Susan knows about her obsession with fidelity, and measure outcomes to assess the extent to which the intended services are indeed those being delivered. She studied messy problems in messy contexts, determined to find some simple truths that could be applied. She demanded rigor. She focused on dual diagnosis of mental illness and substance use, medication polypharmacy and switching, how to use claims data to improve care. She was also an incredible leader, a chair of too many committees to count. Dr. Essock thus endowed the Essock Lecture, which is to be given by a mental health scholar whose work exemplifies one or more of these components. So thank you, Susan, for being you and for endowing this award, which gets us the opportunity to hear from scholars like Dr. Berry. Now, the first recipient of this award was our very own Dr. Melanie Wall, and who continues to grow and just be amazing. And I'm glad to here again to introduce the second recipient, Professor Colleen Berry. So briefly, Dr. Berry is the Fred and Julie Soper Professor and Chair of the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Her academic journey included Drew University, the Harvard University John F. Kennedy School of Government, where she got an MPP, and the Harvard University Graduate School of Arts and Sciences, where she got her PhD in health policy. I wouldn't normally read the title of the dissertation, but I think the dissertation gives a sense of where Dr. Berry started. Her title was The Political Economy of Mental Health Parity. And the story of the mental health parity bill is really important in the history of policy. And this is what got Dr. Berry her start. She spent 6 to 7 years at Yale before landing at the Hopkins School, and she is now the boss of that department. Dr. Berry's research focuses on how health and social policies can affect a range of outcomes, including access to medical care and social services, care quality, healthcare spending, financial protection, and mortality. In addition, she conducts empirical research to understand how communication strategies influence public attitudes about addiction, mental illness, and gun violence. And I find this work so incredibly clever and innovative. A focus of this work is to identify evidence-based approaches to reducing stigma. She also leads ongoing research to track national public opinion on policies aimed at reducing gun violence. Her research has been funded by the NIH, by the National Science Foundation, the Robert Wood Johnson Foundation, the Commonwealth Fund, and Arnold Adventures. Just a couple of more points I want to make. She was the founding director of the Johns Hopkins Center for Mental Health and Addiction Policy in 2015. She was elected to the National Academy of Medicine in 2019. And she is the co-chair of the Forum on Mental Health and Substance Use Disorders, the National Academies of Science, Engineering, and Medicine, starting in 2019. And I want to just read 2 quotes from 2 of our faculty who worked with Colleen. The first is Mark Olson. One of Colleen's amazing qualities is that she understands better than anyone I know how to sift through complex healthcare policies and seize on their most important features for public health. Time and again, she is able to put in perspective key aspects of policies that are easily missed or overlooked. And then from our first recipient, Melanie Wall, Colleen's body of research and her leadership in the area of addiction policy is incredible. I think of her, and I suspect many others do too, as the person who knows everything about this topic, from the intricate details of policy changes to the broadest vision for how to create real practical change. And on top of all of her esteemed research, everybody says that she is a great person and just really fun to work with. So we're so glad to have you here and looking forward to your talk.
Thank you, Lisa. I am thrilled to be here. I'm so grateful to be able to be a part of celebrating Susan's incredible career. I'm thankful for those kind words and would reflect them all back on Susan and the type of leader that she's been. Before I get into the presentation itself, I just want to say that I've known Susan Essock for nearly 20 years. I met her when I was a graduate student, and she has been a tremendous role model for me, including along the dimension of how to be a strong, dedicated senior female faculty member doing high impact work in research and policy. Susan was on the ground floor and a real scholar and implementer and visionary model for so many of us in the field. And it's just been great to watch her career and to learn from her over the years. And most recently, you had mentioned the National Academies Forum on Mental Health and Substance Use. And I had the pleasure of doing that work with Susan, which was a joy and a great experience for me to continue to learn from her. I am so thankful to have the opportunity to talk about stigma reduction today. When we first conceived of this talk, it was going to be in person, so I'm sorry not to be able to be there. Not sorry that I won't miss potentially getting stuck in a New York City snowstorm, but sorry not to be with my colleagues and most importantly with Susan and the past recipient. I hadn't realized that it was Melanie. That's just fantastic. Another great role model. Talking about stigma is, I think, very appropriate to talk about in the same breath that we are celebrating Susan's career, and also at the same moment that we're struggling to manage this devastating pandemic. Susan's career, as you rightly noted, Lisa, has been focused on improving the lives of our society's most vulnerable individuals. This is the same group that is subject to the highest levels of stigma in our society, and also those who've borne the brunt of the impact of this devastating pandemic. And before I pull up my slides and get into the meat of my talk, I want to just say, and this was clear from your introduction, that my training is in health policy, policy evaluation, and my interest in stigma and the research that I've done in stigma doesn't reflect my core disciplinary training, but is an outgrowth of my interest in advancing evidence-based policy. I think we know an enormous amount from a policy and services standpoint about how to improve health and well-being of individuals with mental illness and substance use. But what became fairly clear to me, even at, I would say, a pretty early stage in my career, was that more often than not, we know what to do, but we aren't doing it. And we continue to see these stark differences in the way mental health and substance use and people with mental illness and substance use are treated relative to folks with other conditions, special regulatory practices, and ongoing legacy of separation of systems, of financing, of payment. And sometimes there are good reasons to treat people with mental illness and substance use disorder differently from the way we approach folks with other chronic health conditions. But more often, there's not a good underlying reason. We see these patterns of ongoing differential treatment, and you referenced my dissertation, so I've been thinking about concepts around parity and equity and fairness and discrimination for a long time. And this has prompted me to fall into this habit of using this little test or mental shorthand or exercise. So if I see a context where people are being with mental illness or substance use disorders are being treated differently or separately from people with other conditions, I ask myself, is there a good, clear, concrete, evidence-based reason for the difference? And sometimes there is. But if there isn't, I label it stigma. And often it is. Try it out. You can do this at home. And these differences often reflect systems that were set up so long ago and have been so long-standing that we don't even recognize or notice the difference. So for me, this led me down a very different research path. So like 85 or 90% of my work is in traditional sort of policy evaluation. Does this policy work like it's intended? Are there unintended consequences? But increasingly, the awareness that studying stigma is critical to getting evidence-based policy enacted and implemented. And it prompted, and so I dipped in and started to learn some new methods to do that work. And one of the most stark early realizations for me in trying to dip my toe into being a stigma reduction researcher was the near absence of evidence base for stigma reduction. Stigma is widely acknowledged as a major barrier to connecting people with high quality mental health and substance use care, but very few of us in the field were actually studying it. Some of us have been writing think pieces about it. Sometimes we even document it through descriptive survey research, through descriptive qualitative research, but almost nobody was conducting research trying to identify ways to combat it or eradicate it. And we see and have seen anti-stigma marketing campaigns in mental health and addiction that have by and large not been based on any rigorous research. In nearly all other areas of health and medicine, we rely on well-designed research studies to establish evidence on effective interventions. You noted this, Lisa, a few minutes ago in the sort of foundational principles of how Susan led her career. In contrast, when it comes to mental health and addiction, efforts to reduce public stigma through communication campaigns are seldom grounded in anything more than intuition. And I'm going to just say that again, seldom grounded in anything more than intuition. Why is that? So that's what I want to talk about today. And I am going to bring up my screen to do just that. So here we go. And I'm just going to check with you. Lisa, give me the thumbs up if you can see the screen. Perfect. Great. So let me just begin by talking a little bit about stigma as a concept or construct. And anyone that hasn't read this great piece, it's an older piece, 2001 by Lincoln Fellon. I encourage you to do it because it's wonderful. And I pick it up like every year and reread it. And what they talk about is the term stigma includes elements of labeling, stereotyping, separation, status loss, and discrimination that co-occur in a power situation that allows the components of stigma to unfold. And so the idea here is that the power differential is at the center of this constellation of components of what constitute the process of stigmatizing in our society. And this actually is interesting because often when I have an article that's under review that's focused on stigma, I get the the critique that what I'm talking about is more discrimination than stigma. And I think the interesting thing is that I think it's worthwhile emphasizing that discrimination sits within stigma in the conceptualization by Lincoln Felon. So public stigma involves pervasive negative attitudes and beliefs that lead society to reject people with addiction or mental illness. It contributes to and is perpetuated by structural stigma, which manifests in discriminatory institutional practices and policies. So that's my focus. That's what got me here. And self-stigma occurs when people with addiction or mental illness internalize society's negative views. And we know and see every day in our lives, for those of us that work with individuals with mental illness and substance use, that stigma operates at multiple levels. At the individual level, through riskier behaviors, through social isolation; at the health system and provider level, through poor quality of care, and the profound underinvestment in training and treatment infrastructure in our country that is true today and has been true historically. And at the societal level, social stigma translates into discrimination in jobs, housing, insurance coverage, neighborhood resistance to offering life-saving services, greater support for what I call punitive policies, shaming or punishing policies that then trade off and allow for less support for public health-oriented policies. We see this well documented in lots and lots and lots of public opinion data related to stigma. This is like one little tiny piece. I use the slide because I think it's interesting that it lines up drug addiction and mental illness. Like this is, let me just be clear, this is like a huge oversimplification, and we do have the work that looks at different conditions within the bucket of what is mental illness and the bucket of what is drug addiction. But I think this sort of illustrates the main points, which is that when we think about core stigma measures, which are the so-called social distance measures that have been used most prominently by the General Social Survey, unwilling to have somebody with a specific mental illness or a specific drug addiction marry into your family, unwilling to work closely on a job, unwilling to have this individual as your neighbor. Very high levels of stigma and higher levels of stigma for addiction even than mental illness. A willingness to accept discrimination in housing and employment, lack of belief in the effectiveness of treatment. Interestingly, less stigma around the concept of the ability to recover. But interestingly, I tend to interpret that, it's my own interpretation, I don't know whether it's right or not, but as sort of a pull yourself up by your bootstraps. You could just recover if you would, put the work in to make it happen. And then in the policy dimension, and these are just a handful of policies that I threw into this slide, but we see this with almost every important policy that we look at, high levels of opposition. Here, I just want to put this slide in people's minds. And so one interesting thing that's different about mental health and addiction is in the context of mental health, if somebody has a personal experience, either themselves with mental illness or through a close family or friend, it actually lowers stigma rates pretty significantly. This has been shown in a couple of different studies. We see actually the opposite in the context of addiction. Having personal experience either makes no difference, no statistically significant difference in having stigmatizing attitudes, or in some cases, it increases the levels of stigma ratings, which I think is important. We tend to throw mental health and addiction in the same bucket far too often. And I think they operate along various dimensions in slightly different ways that are worth sort of digging into and understanding well. This is just an exemplar slide to make the case that clinicians and other public health professionals within housing authorities, within social service systems, within criminal justice systems have levels of stigma that are similar to and some cases higher than the general public. NIMBY attitudes related to some of our most critical and evidence-based tools for supporting people with addiction and mental illness. And we see news media and media more broadly that reinforce these stigmatizing views. So the role of the news media is an important one. Americans get much of their information about health issues from news. News media coverage can influence public attitudes about the significance of a problem, the public's knowledge about a problem, perceptions about the consequences of a problem, support for solutions to a problem, and attitudes, most importantly, and this is sort of the core here, attitudes about the population affected by a problem. And there are lots of different methods that I'm going to talk about during this presentation that we bring to bear to try to sort of quantify all this stuff. News media quantitative content analyses are one thing that our group has used, as well as message framing experiments, randomized experiments, to try to both understand stigmatized portrayals in the news media, but then to try to develop strategies to correct them. And sort of the question here is one of reframing. So I think about this sort of the frame. To frame is to select some aspects of a perceived reality and then make them more salient in communicating context in such a way that promotes a particular problem definition, causal interpretation, moral evaluation, or treatment recommendation. So a frame directs the eye and it directs our minds to certain features of a scene over others. And this is the overwhelming and powerful role of the news media and other sort of communicators and thought leaders that are guiding us in how to think about, in the case of this presentation, individuals with substance abuse and mental illness in our society. So we can think about classic framing experiments. These are like the gain-loss frames from Kahneman and Tversky, but rarely are the frames that the media describes classic equivalence frames. Instead, these have to do with rhetorical styles, differential interpretations of topics, words or phrases that tap into pre-existing views that we have. And there's a huge body of research literature that suggests this framing is enormously important in determining what we think about and how we think about it. And what we see from the news media is very specific messages being transmitted to the population about individuals with mental illness and substance use disorders. This is from a study that we did looking at a 10-year period, and we see that this is a broad, large database of news articles from all sorts of different national and regional outlets, both television and print. It doesn't include new media, it's an older study, but we see that over half of news media stories about people with mental illness framed the story in the context of violence, over half, and nearly 40% specifically related to interpersonal violence on the part of the individual with mental illness, mostly as the perpetrator rather than the victim, whereas we know from an epidemiological standpoint that people with mental illness are more often the victims of violence, and a very relatively small share of news stories talked about treatment that was successful or stories of individuals in recovery. And this always reminds me of this quote. This is a psych services quote, Lisa, from a few years ago from my friend and colleague, Steve Sharfstein. We will we ever see an end to the stigma that is associated with mental illness? Steve asks. No, not as long as there are untreated, delusional, disheveled, threatening, homeless individuals on our streets and in high-profile media examples of violence. We see this, and part of what, I've always been interested in mental illness and substance use. What got me interested in gun policy and framing of gun policy, and that sort of whole line of research that Lisa talked about, was this troubling framing of a link between gun violence and mental illness, and the policy implications related to what it means for policy if we're focusing people's attention on dangerous weapons, or if we're focusing people's attention on dangerous people, and what that means for our field to have that link to mental illness. And I'm going to talk a little bit more about that later. We did this experiment with my wonderful colleague, Beth McGinty, who's been a great partner in so much of the stigma reduction research that I've had the privilege to do, and with Daniel Webster, who runs our gun policy center. This is part of Beth's dissertation, where we did an experiment, and this article was published in the American Journal of Psychiatry, and we see that compared to a control arm, the effects of a news story about mass shooting on perceived dangerousness of people with serious mental illness is significant and large. That is just the exposure to news media stories about mass shootings drive up the perception among the general public that people with mental illnesses are dangerous. Here, just turning to the opioid crisis, a history of depictions of people in a criminal frame, as opposed to what I would think of as a more of a public health frame, or a treatment frame, in the context of how to think about the problem of opiate use disorder, and a lot of misinformation being conveyed through the news media. Here is just one example, the perpetuation of the incorrect notion that opiate use disorder medications like buprenorphine and methadone are just treating one form of addiction for another at quite high rates across a large and diverse sample of news media sources. And this is from a study we published a couple of years ago in Health Affairs. So the goal is to use communication research to change the frame. Can we shift stigmatizing attitudes through the way we communicate, both to the broader public, but also to the subsets of the public where individuals with mental illness and substance use disorders most frequently interact, including but not limited to the health profession. And in doing so, increase support for evidence-based public policies that are grounded in a public health orientation, and a shift away from policies that are highly punitive. So I'm gonna do, this is, this would be maybe a little cooler if we were all together, but I'm gonna try it anyway. I'm gonna show you some just quick clips from some anti-stigma campaigns, not the video. I'm not gonna try to get into making video work in a Zoom format, but I want you just to have a mental cue card in your head. Green means this is something that will decrease stigma. Red means this is something that's going to increase stigma or will have no effect, is wasted resources, like marketing campaign that's not going to make a difference, and those funds could be directed in some better way. Or yellow, you're just not sure. You don't have these cards in your hand, but mentally raise them as I go through. And I'm just going to pause on each image and have people just quietly reflect, and maybe we'll come back to this in a minute. So this is bus in the city of Philadelphia. We're living proof that BUPE works. Here's the same campaign, same slogan, a mom with presumably her 2 kids. Here is a slogan, there is a way out of opiate addiction, and you see a Black man behind a bar of pill bottles. This is to promote safe consumption spaces. You have a story of a young woman and her childhood photo and her struggle that allowed her to overcome addiction. Here is the State Without Stigma campaign that folks might be familiar with from the state of Massachusetts. Addiction is not a choice, it is a disease. Here is a photo with the slogan, "The first weeks of my life were spent in detox, opiate withdrawal, and some of the associated effects." Here is a photo of a woman. "I'm living proof that buprenorphine treatment works. Of all the treatments I've tried, buprenorphine is the only thing that's worked for me," and then goes on to talk about the things she's done, including simple stuff, but also the joy of the relationship with her daughter. This is, I'll just note while I'm here, a $1.4 million campaign launched by South Dakota. "Meth, we're on it" is the slogan. Here is a story that was developed through Sesame Street related to character Carly and recovery. Let's do words for a second. Same idea. Addict, person with a substance use disorder, opiate replacement therapy, drug habit, medication-assisted treatment, substance abuse. And finally, and I'm going to do this one quickly because I don't like this slide very much, I'm going to go through some images. Okay, so what do we know? From strong, high-quality empirical research, primarily randomized experiments about what can effectively drive down stigma, and then what translates into increasing support for policy. Together with some colleagues, we've begun the process of putting together an evidence base of principles for stigma reduction. And I have my spoiler alert here, which is that we know not very much. There's so much we still need to learn to build this evidence base. And to the extent that those of you who are participating in this webinar want to be part of building that research, there is a wide open, wonderful field of high impact work there to be done. Here is an article that Lisa published in Psych Services a couple of years ago, where together with a couple of colleagues, including again, Beth McGinty, Bernice Pesca-Solido at IU, who's been a tremendous leader in this area, coming from a sociological standpoint. So that's been great to work cross-discipline to do this work. Aline Kennedy Hendricks at Hopkins, to try to put together a paper that's sort of laying out some of the evidence base. more recently, Beth and I published this paper as a perspective in April of this year in the New England Journal, and this one is focused more specifically on stigma reduction to combat the addiction crisis. Again, the call to develop an evidence base. So I'm going to go through quickly each of these principles and pull in a little bit of the research evidence, and then hopefully have some time to talk about these issues. And I will say, again, this is like, I didn't spend 7 years of my life developing a training on how to become a stigma researcher. This is like a labor of love. I think I've maybe, of all of the funding I've received for my research in a soft money research environment, I've received like almost none of it to do this work, so this is, now I'm discouraging people maybe from becoming stigma researchers, but it really is a labor of love because of the profound importance I think it can have on the field. So number one, use of person-centered language is essential. Number two, common sense, intuition-based approaches may not work and may have unintended consequences. Number three, emphasizing solutions such as treatment works appears to reduce stigma. Number four, use of sympathetic narratives, stories that humanize people may reduce stigma, but the devil is in the details. And these narratives, which are so very popular, can open us up to some serious unintended consequences. Number five, stigma reduction messages should emphasize societal rather than individual causes. This is very much connected to the sympathetic narrative point above, and I'll get into why in a minute. And number six, emphasizing violence drives up stigma. And this is specifically connecting to my point related to mental illness and violence from earlier. Okay, number one, person-centered language. So person-first language, I think probably most folks in the grand rounds know, emphasizes the individual before their diagnosis. Another way to think about person-centered language is using the term preferred by the person of interest. So there's been actually the largest body of research that has documented increasing rates of stigma associated with the use of specific words. So here is just one example of the study. This is a study that was done by John Kelly a decade ago, and it's been replicated by various folks, including by our group, and lots of these experiments have been done. This one specifically shows that use of a term such as substance abuser is more likely to exacerbate stigma than use of person-centered language, such as a person with substance use disorder. So using the term substance abuser increases the public's perception of individual culpability of the individual for the condition, the belief that a person should be able to self-regulate their substance use, the belief that a person should receive a punitive rather than a therapeutic response. We've had some really important movement around using person-centered language over the last few years, including this directive through the Office of National Drug Control Policy when Michael Botticelli was director, related to changing federal terminology related to substance use and substance use disorders. In 2017, the AP, which is the Associated Press, which is the document that journalists should use as the foundation for style and standards, made a revision speaking to language around substance use. This built on a 2013 similar style guide change related to mental illness. And here I'm sticking with the theme on the substance use side, identifying the words. So the research base relates to identifying words that drive up stigma and identifying alternatives and persuading people to use those alternatives. And there are lots of ways to do that. One that I'll highlight is a Words Matter pledge. This is a pledge. There are actually 2 pages of terms. It's just the first page, but the Words Matter pledge, this is one used by Boston Medical Center that Michael Botticelli implemented when he was there. We're in the process of developing and launching a Words Matter pledge at my own home institution at Johns Hopkins Medicine. Raising awareness, raising sensitivity to the importance of the issue. So just quickly, I'm gonna present a little bit more news media content analysis data. The question is person-centered language used by the news media? So we published a study where we focused on terms that had been shown in experimental research to significantly increase stigma rates. And we examined a large, diverse sample of news stories on the opiate crisis during the period 2008 to 2018. 49% of news stories used at least one stigmatizing term. So basically half, and 2% of news stories used at least one less stigmatizing person-centered term. So this is what, it's not like the study was done like 2 decades ago. This was like up to 2 years ago. So you can see that basically, you know, and the tick up in person-centered language was just in the last couple of years. Okay, number 2, common sense, intuition-based approaches may not work and may have unintended consequences. So like this, I think, is really the sort of the risk beyond the fact that we're a research community, we believe in developing evidence-based for interventions, but going with intuition, as in many areas of health and medicine, can be off. And we've seen it dramatically off in this area. So this is a great study published about a decade ago by Bernice and her colleagues called A Disease Like Any Other. This is using the General Social Survey. And I think this study offers an important cautionary tale. So the bottom line here is that launching stigma reduction campaigns without rigorous pre-testing of messages can lead to a waste of resources and unintended consequences. So the aim to reduce stigma, so the goal here was to reduce public stigma by framing mental illness on par with other chronic conditions. So like the just like diabetes message, which to me makes total sense. Like this has absolute appeal. It's outgrowth of the philosophy of parity, but it failed, and it's dramatically failed to reduce, and by some measures has actually increased stigma. Why? We don't know the answer. One possible explanation for the failure is the emphasis on mental illness as a disease heightens perceptions of permanence, increases pessimism about recovery. Whether that's the pathway or not, the important point here is that it doesn't work. Yet, just as recently as the past couple of years, we've seen prominent reputable organizations like the Massachusetts government focusing on disease like any other messaging. So the important question is it still true? Is it true of addiction in the same way it's true of mental illness? Those are important studies to do that haven't been done. Emphasizing solutions appears to reduce stigma. So we did this this study that was published a couple of years ago in Social Science and Medicine, together with Howard Goldman and Bernice again and Beth again. And what we did, this was a randomized experiment. So we exposed nationally representative samples in treatment arms and control arms to vignettes about untreated symptomatic people with, I think, 3 different substance use disorders and 4 different mental illnesses. And in all cases, relative to a no exposure control arm, those vignettes increase stigma. Exposure to vignettes about effective treatment lowered stigma across all of the dimensions that we mentioned, lowered desire for social distance, increased beliefs in treatment for controlling symptomology, reduced support for discriminatory policies. These were powerful effects. We see solution messages increasingly being used. Medications for opiate use disorder save lives. In another study, this one published in the American Journal of Public Health, we showed even small wording changes. In this case, 3 words made a big difference in support among nationally representative samples of the public. So here we substituted safe consumption site for overdose prevention site. Just those 3 words, and the 2 split samples got the rest of the language identical, which is basically a definition of what this policy was. And we see a 16 percentage point difference in support for overdose prevention site. Again, I don't know exactly what the mechanism is, but I think it has to do with focusing on what the purpose or the solution that's being proposed by this programmatic lever is, that is reducing overdose deaths. It's just another example of the treatment works messaging. We haven't studied this specific message, so I don't know that this one works per se, but it has some of the elements that have been shown in other places to work. Sympathetic narratives can reduce stigma, but the devil is in the details. So here is a study that we did with our colleague Marcus Bachhuber, where we looked at, this was a randomized experiment, and we looked at support for a variety of different naloxone distribution policies and whether support was affected relative to a no exposure control arm by factual information alone, by a sympathetic narrative alone, and then by a combined messaging that combined sympathetic narrative with factual information. You can see, for example, the policy that had the lowest sort of baseline no exposure support, that of providing naloxone to friends and family members, was greatly increased in the arm where you combine factual information with the sympathetic narrative. So why are narratives so powerful? Narratives engage in the sense that they're more likely to elicit emotional responses, sympathy, but also, again, caution, anger, than purely factual content. The transportability aspect of narrative, they can facilitate understanding of alternative perspectives and experiences. Counter-arguing, that engagement in another person's story can increase receptivity to another perspective by reducing counter-arguing. All of these have been shown to be characteristics of narratives. And in these ways, narratives can be an effective vehicle for reducing stigma if they include certain elements. So sympathetic depictions, highlighting of external contributors to a person's condition, and I'll get back to that one in a minute, featuring effective treatment and emphasizing positive outcomes associated with recovery, as well as refuting common myths. The challenge is communication theory and empirical work supports this communication theory, talk about, to get back to framing, thematic frames and episodic frames. So think about the news media. This work by Iyengar in political science has been done sort of typically in the context of thinking about news media framing, like I was talking about it before. So thematic frames are stories, news stories that contextualize an issue and situate it within broader trends that can heighten recognition of system level contributors, which can reduce individual blame. So the idea of thematic frames is highlighting what's going on at the system level, so there's less of a sort of motivation to blame someone on their circumstances based on their individual behaviors and choices. Whereas episodic frames focus on a single episode and do not provide broader context in the sense that they often reinforce the individualizing of problems and heighten blame. And you can think about news stories that you've read that are trying to sort of hit a thematic frame, but much of news media coverage of stories is episodic in nature. And we know that individual blame is strongly associated with stigma. Narratives are typically episodic, so they're frequently featuring featured in news media. They are turned to often by advocates in an effort to humanize. And the risk here is triggering individual blame. And so I wonder, I haven't studied this, but I wonder about this image and whether putting a woman who has a history of drug use in the context for kids without a broader contextualization can in fact potentially trigger increased blame in a way that's totally unintended in the context of what otherwise I think would be a powerful message. Here is another more obvious example of this. 5, anti-stigma messaging should emphasize societal, not individual causes. So there's a bunch of research here. I'm going to talk just about one study that was done by Aline Kennedy Hendricks. This is a randomized message testing experiment that was published in the Journal of Health, Politics, Policy, and Law, that shows that a sympathetic narrative describing the experience of a pregnant woman with opiate use disorder reduced the degree to which the audience blamed the woman for her addiction only when barriers to her ability to access treatment were highlighted. So when you talked about challenges related to getting childcare and insurance barriers and transportation barriers and the treatment clinic being 2 hours away, all of those things that we know from a policy standpoint stand in the way, no availability of effective evidence-based treatment, all those things that we know from a policy standpoint are barriers to people getting the care they need. Those messages were able to, in the case of this experiment and a couple of others that have been done, lower stigma. Last one, emphasizing violence backfires. So here's a study that a group of us did related to this question. And this is something that I had thought a lot about for actually quite a few years before we did this study. And so there's been this argument out there, many of you, I'm sure, are familiar with it, that violent portrayals of people with mental illness would increase public support for expanding mental health services because they highlighted the need for these services in our society. So we ran this multi-arm randomized controlled trial using nationally representative samples, which we always do, to try to understand this. And what we found out was that this was actually true. But along with increasing the public's perception of the need to expand mental health services, these messages, unsurprisingly, substantially increased stigmatizing attitudes. And I think the bottom line here for me is they were equally effective as other strategies for driving up awareness and desire for increasing public support for mental health services. And those other messages don't drive up stigma, and this message does. So why would we ever rely on this as a strategy for highlighting the need for investing in services and systems? The price of stigma heightening, as far as I'm concerned, is just way too high. So there's so much else. I'm like basically out of time now. I think if we had more time, we could talk about the importance of not just messages, but messengers. The really important point, and I'm just going to say one quick thing about intersectionality here, that we are talking about stigma toward individuals with mental illness and substance use disorders, but stigma is often multifaceted in that you have individuals, often the individuals that we're most interested in helping, that are hit by multiple levels of stigma related to race, related to sexuality, related to disability, and related to the topics that we're focused on today. So many interesting and important questions related to what's happening with stigma and with stigma reduction efforts in the context of the pandemic. And more. My final word, I'm just gonna do a quick addendum to the study that I mentioned a couple of minutes ago about the power of highlighting external barriers preventing people from getting into treatment in the context of the pregnant woman. So that was a randomized message testing experiment led by Aline Kennedy Hendricks. And we saw that the narrative reduced stigma by highlighting these external barriers to getting effective care, but only when the pregnant woman portrayed was a high socioeconomic status woman. An otherwise identical narrative, everything identically the same, except the socioeconomic status of the woman highlighted in a couple of places, in a couple of different ways in the narrative. The identical narrative about a woman with low socioeconomic status failed to reduce stigma in the identical experiment, which I think is a really important cautionary tale to how well these strategies work in different populations, in particular populations where we have multi-layered stigma. Last slide. So lots of things to be done here. It's possible for those interested in doing this work to initiate a Words Matter pledge, to pull together stigma reduction resources, to host a journalism training, to host a stigma reduction boot camp for system leaders interested in stigma reduction, to conduct webinars like this one. Larger steps would include jumping into stigma reduction research to build the evidence base, helping develop strategic statewide stigma reduction planning, and creating a stigma reduction speakers bureau. And here are some resources, and I am going to stop sharing and turn it back over to Lisa. Oh,
wow,
you're muted.
I'm good now.
Good.
Wow, I'm really covered a lot of territory, and I can see some questions that I will. I would love for the people who wrote the questions to ask questions. Oops. So Flavio, hold on. Sorry. Do you want to unmute yourself so you can ask your question? And Sydney's up next, and Rebecca. So give you a minute. Well, you know what? I'll start, and if Flavio jumps in, he'll jump in. So thank you for a great presentation. Oh, here he is. I see him coming.
Okay. Can you hear me?
Yes, we can.
Okay, great. Wow, that was a great presentation. Thank you so much. You know, we've been doing several initiatives on trying to increase sort of different treatment practices in our clinical settings. And one of the ones that we're seeing resistance is on treatment of tobacco use disorder. We often hear from clinicians that this is not something that belongs in mental health. You know, we're okay with giving a patch or some gum to avoid craving, but we assume and generally accept that people will just restart using nicotine after they're discharged. Do you think this falls in the category of stigma? How does this fit into the presentation, kind of the frame of stigma that you presented?
Yeah, so thank you, Flavio, for that great question. I think tobacco use is such an interesting case, because I think the strategy, the dominant strategy for trying to reduce tobacco rates in our country was stigmatizing tobacco use. And so there's a long history with some, I think, good life-saving motivation under it to stigmatize tobacco use, to reduce the use of its product. The problem with that is that often when we are stigmatizing something that is a product, we stigmatize the person associated with that product. And so when you think about higher rates of tobacco use among, for example, individuals with mental illness, we are all of a sudden in the box of subjecting individuals to multi-layered levels of stigma and forgetting our evidence base. And it seems like a great example of that. And all of this, I think, gets back to the unintended consequence of that behavior, which is driving people away from effective treatment. So certainly, it sounds like the case that you're describing falls into that category, which is terribly unfortunate in a clinical healthcare setting.
So, Colleen, if I could follow up Flavia's question. How would you design a study using the principles that you've outlined to address this problem among, say, I mean, so part of the problem is really within is the providers, right?
Yes, yes. Yeah, so I think one thing I'll say is right now our team is in the process of a communications campaign that's directed toward providers within the Johns Hopkins healthcare system. And that campaign is related to substance use disorder. And there are sort of two prongs of that campaign. One associated with changing attitudes related to life-saving FDA-approved medications for opiate use disorder. And the second is related to words and language. And so I think the approach that we're using in that campaign could be sort of translated into any communications campaign that is targeting healthcare professionals or any other professional group too. We have a similar project related to the criminal justice system and professionals within the criminal justice system. So I think the first step is identifying sort of where the area of stigma is, sort of what's going on that is stigmatizing and what is the potential negative implication. And often, as I said before, it's that you're driving people away from life-saving care that can help them. The second step is to identify what some potential interventions are and who the targets of those interventions are, and then sort of test the effectiveness. So it's just, this is like intervention research, right? And two things I want to say about that. First, when interventions are launched within the healthcare system, I think that it's really important not to just think about doctors or not to just think about nurses. To go back to my example of an individual with substance use disorder, you can be turned away from the health system at that very first interaction, the moment you walk into the door and you're treated negatively by a front desk staff member. And so I think thinking about the audience in a broad and deep way is important. Then what we're doing in our setting, and could easily be done in any setting, as we develop our communications campaigns, there are posters where they go, there are also messaging campaigns, and we throw them into a randomized experimental setting, and we see whether they work. Once we know they work, meaning they change people's attitudes around things that we want to change, then you can launch it in a healthcare setting in a targeted or a broad way. Those are, fairly straightforward steps that any health system can undertake to change behaviors on the part of healthcare professionals typically and regularly unintentional that might be standing in the way of individuals receiving the evidence-based care that could benefit them.
Thank you. I think, so Flavia, you got some work to do this afternoon, maybe?
Flavia, we'll do it this weekend.
So we have a number of questions that are popping up, so I want to try to move on. So Sydney Hankerson, I don't know if we can get Sid. There he goes. Okay.
You guys are great with technology. Hi, Sydney.
Hi. Thank you so much for such a wonderful presentation. I have two questions. One, could you share your views on how to frame, anti-stigma messages related to opioid deaths from fentanyl and other synthetic opioids, especially in communities of color? You talked about this a little bit with the intersectionality.
Yeah. So, so number one, we don't know. We do not have good evidence for how to do this well. There have been almost no good high quality communications work looking at the intersection of opiate use and racial disparities in our country as sort of a basic statement. And then very little that's been done to try to target reductions in fentanyl deaths. Baltimore City had a pretty cool campaign that only a process evaluation was done. So there wasn't sort of a formal randomized message testing experiment. What they did, it was called their Go Slow campaign. And the idea was it was harm reduction in orientation. And the idea was to raise awareness among people using drugs and this was early on when people didn't know whether there was fentanyl in their drug supply. Now, I think it's well known that, most of the drug supply in Baltimore City is fentanyl laced. But at that point, start slow, make sure you're okay. And that message in pre-testing and post-testing with people using drugs in the city was viewed as helpful and life-saving. But I think you've, Sydney, tapped into a critical area where we just have almost no tools to prevent overdose deaths. And it's a critical area of need.
Sid, do you have a follow-up, I think?
Oh yeah, Sydney, did you have a second one?
He wrote here, in general, how do you translate results from stigma reduction interventions into health policy?
Yeah, so this is, where we in the research community really need to partner with policymakers and advocates. I am forever humbled by my lack of training as a policy advocate and a effective translator. And I think increasingly we are obligated to get outside our research bubble and be talking to people about how best to use the information that we are producing. And it's hard and it's messy and it can be challenging, and often there are timeliness issues. I want to do a study and someone wants to get a campaign out now because people are dying, and both those things are true. So one thing that we've tried to do is to be nimble and to move quickly and to be good partners and to be willing to go and speak in community groups and to speak to people that can make a financial investment in this area. There are actually a lot of funds at the state level around stigma reduction, and folks that don't know how to spend those dollars on effective communication strategies that can make a difference. So there's a need to make the research to policy connection here. But what we need most to begin with is better quality research to inform policy.
Maybe we need to study how to communicate to policymakers. So
yeah, that too.
Edit yourself crazy. Okay, so Ezra Susser, I think, has the next question. Go ahead, Ezra, if you can.
Okay, that's a wonderful talk. Thank you. I wanted to ask you what you thought the role of culture might be in modifying the effects of the strategies that you mentioned could be successful, either increasing or decreasing their impact. And I'm thinking of, in the US, the randomized trial that Bruce Link led in Texas, where he compared Latinx high school students, with white high school students. But I'm also thinking more generally about variation, the vast variation in cultures across countries, across regions, and, including low-income countries. Just like your thoughts on that.
Yeah, so that's a huge question, Ezra, and I'm only going to be able to partially answer it, and probably not in a satisfactory way, but I will try. I think, the first thing I want to say is that what you've hit on is that we need to think as much about messengers as about messages, and who the target audience is for our messages. And the same messages might not work equally with all groups and across all cultures. So I work closely with the Center on Communication Programs at Hopkins, and they are funded to do communications campaigns, mostly aimed at behavior change rather than policy change and stigma reduction. But the principles and the methods are the same. And their work, and so they're doing these campaigns all over the world. And the first thing that they do is they partner with local organizations to make sure that the communications campaigns that they're developing are embedded with the expertise that's necessary to understand how messages will be received. And they've actually been doing a lot of messaging work on COVID all over the world right now. And these messages about what to do take really different forms. I just listened to something that they put out on the breadth of the messaging across like 6 or 7 different countries, and then within one country across different areas. And that specific country was within Africa. Really different messages targeting different cultural settings and beliefs. And so that is even harder than what we've been talking about thus far. Also, understanding who the thought leaders are. So one thing that we've done with our health system experiment is we've set up, again, trying to increase support for and knowledge about life-saving FDA-approved medications for opiate use disorder, and signal the importance of language and language mattering at our word choices. Those 2 campaigns, we have 3 different arms for each that we're comparing to a no exposure control arm. One arm is from an individual themselves, talking about their own experience with stigma. Nearly the same identical message coming from a provider and then from a health system leader. And so we're in the field right now with the study. The question is, does it matter who the communicator is and how the message is received? The last thing I'll say is, in some work that I'm doing related to COVID, in really highly politicized issues, message development needs to be done with sort of the target population in mind. So political ideology, underlying beliefs related to trust in science, those things matter extraordinarily. So we try to understand baseline trust in science, for example, and then develop differential messages based on sort of where people are coming from.
Okay. Thank you. We're getting more and more questions. So Rebecca Owens.
Yep. Hi. Hello. Hi, Lisa. Hi, Colleen. Right. So my question, Colleen, thank you for this work. I started my clinical training as an emergency department nurse, and I am just still remembering all of the stigma that I observed when somebody would come in with an overdose or an alcohol blackout problem, or either first break or repeated mental illness episodes that required stabilization, but then also required aftercare, and you talked about words matter and so on and so forth. And in crisis, what I saw was that a lot of my colleagues were not really sensitive to the fact that there is so much stigma already around, around these patients. And I was just curious if any work has been done on stigma in the emergency department setting. I covered both medical and psychiatric areas when I was there. And if there have been, I'm curious as to the findings. And then I just wanted to make one comment on the ads. I mean, I generally do not believe most of the general public actually would even know what BUPE, B-U-P-E.
Totally. Yes.
No, you're right. So what?
You get extra credit, Rebecca. No, no kidding.
So like millions of dollars for these huge billboards. And I'm like, nobody's going to know what that means. Half of the clinical people don't even know what that means. So anyway, I just was laughing at that in kind of a sad way. So thank you.
Yeah, so I totally agree on that last point. A little pre-testing dollars would have gone a long way there, right?
Right.
So in the ED setting, so we know descriptively that stigma rates are high, and we have some understanding of why that is the case, not differentially high from the rest of the health setting. But when you think about what goes on in the emergency department, often we are seeing people at their worst, in particular individuals in crisis related to substance use or in crisis related to mental illness. And that is a setting where stigmatizing attitudes can take hold. The other thing that we have observed in the context of the opioid crisis is emergency department burnout associated with the same individuals coming back again and again, seemingly in a way that is at odds with hopefulness about the ability to find effective treatment and recover. And so it's a really important, interesting setting where we have done pretty much zero work to try to do message testing and communications work. It's a subject of some of the work that we're doing right now within our own health system at Johns Hopkins. One thing that I will say, though, that's I haven't said yet, and I think it's really important, is communications campaigns alone don't make a difference unless they're supported by an infrastructure where people can get the care that they need. And so one thing that when we started these efforts about a year ago, Hopkins, within the hospital, we were just in the process of starting to roll out a consult service. And so we're thinking about messaging within emergency departments and inpatient medicine floors, but those clinicians don't have the tools that they need to get people into effective treatment. And in that sense, building out a communications campaign is just throwing money down the toilet because you're not positioning people to use that information to be successful. I will say that one of my friends joked with me, but it's sort of like not really a joke, that he's like, forget your communications campaign, Colleen, just get some peers into these clinical treatment settings, and they are the embodiment of treatment works. And clinicians that have the opportunity to work with peers are able to see that on a daily basis in a way that's profound and can be transformative. And so there are many different tools that we have at our disposal to lower stigma, but we can't expect busy emergency departments with individual staffed full of people just trying to do their work in the best way they can without building out a broader infrastructure to support the anti-stigma work in a way that's meaningful.
Thank you, Colleen, for pointing out the power of peers. That way back in 1992 in Baltimore, in our homeless study, that experience of having peers on my team transformed me and made me understand. So thanks for mentioning that. Okay, Sally Satel is up.
Hi, Sally. Are you on mute? We can't hear you yet.
I can read her question.
I see that she's on mute
yeah.
there. Let's see if she can.
Okay,
She's off.
sorry about
Hi,
that.
Sally.
Hi, thank you. My question, which I can't see, but it had to do with, just more, I guess in a way more of a comment, but this tension between the public message that maybe you shouldn't emphasize elements of agency on the part of, and I'm just talking about substance abuse now, not like severe mental illness, on the part of the person. But in treatment, that's so much of what you focus on is how the person can change and how important the motivation is. And it's very internal. The focus, the locus is very internal. That was my first. And the second is, what is the evidence that, I don't mean it as a challenge, just what do we know about the translation of attitude change into behavior change?
Great. Okay, so first, let me just write the second so I don't forget behavior change. So the first one related to agency, that's a great point. And one of the, so absolutely critical in a clinical care setting, agency is foundational in getting folks into treatment. And I think one way to square this is to think about joint responsibility and messaging around joint responsibility. We all have a role to play. Like we as individuals with a condition own that condition and are making choices every day. You know, we're not taking choice and agency away, but there are system level factors that make it challenging for individuals to get the care they need if they want it in our society. In the criminal justice system, it's impossible to get life-saving medications. Judges don't understand the effectiveness of treatments and are often mandating things that only hurt people. In our healthcare setting, we too seldom are in a position to give people treatments and supports and connect them with social services in a way that allow them to succeed. And so I think through communications, and I've done this more in other areas, including non-mental health and addiction communication and messaging research, the idea of building in those joint messages becomes important. And the example that I'll give is related to obesity. I think that there is maybe no one out there that's going to be persuaded by the idea that the individual doesn't have any role in their health around sort of what they eat and getting exercise, but being able to build out a message that's all about individual blame and individual responsibility to incorporate into a sort of joint responsibility message, the idea that where you live, the availability of fresh and healthy foods, the ability to get exercise in your community, food marketing, like all of these other extra factors external to the individual also play a role in a disproportionately negative role when we think about people and young people in particular growing up in communities of color, communities that are resource poor. And so I think that we can, we've shown in that context that you can increase support for public health oriented policies when you acknowledge individual agency, but also build out the powerful policy and society role that impacts people in what they're able to achieve. Oh, and the last thing, attitude to behavior change. I have spent much less time thinking about behavior change per se. You know, I'm more of a policy gal, so I've thought more about the connection between changing opinion and attitudes and how that translates into willingness to support different types of policies. But there's a big literature there that makes that connection that is sort of more or less robust depending on where you go.
So thank you. This notion of joint responsibility is cool. We have 2 more questions, and I'm going to read this next. I'm hoping that we can at least get everybody's question addressed, if not in depth, at least on a first pass. So this next question is, how do you deal with substance users who refer to themselves as addicts?
Such a good question. Thank you for that. This, so I've had a lot of conversations with friends and colleagues on this topic, including individuals, and there's a great community of individuals who have a recovery story that are working on message framing work too. So that is a great place to think about this question and doing this work. I think both, it's important to acknowledge that people have the ability to use the language that's meaningful to them, and in particular in communities of support, and that it's also important to educate that language has an effect that can be detrimental when engaging in the broader community. And so, I think generally speaking, I stay away from the business of telling people, in particular people in recovery, what to say and how to say it. I think what I try to emphasize is what we know from the research literature about the effects of our words, and then let people make those choices in the way that is right for them.
Great. Okay, so Jean Marie has the last question of the day.
Hi, Jean Marie.
Hi, how are you? This was fantastic. I loved this talk. I'm so excited that you came today, and I have so many questions, but I'm going to narrow it, and I might contact you later if that's okay.
Please do.
I am highly interested in reducing stigma, attitudes and behaviors toward people of color. I do a lot of diversity work, and I'm really interested in your framework. I really love the way that you frame the talk, and interested in thinking about that as it applies to discrimination. And that leads me to a more general question, which was, in the beginning of the talk where you had the graphic about the elements of stigma, are there easier elements within those bubbles that are better to target first? That's a general. And then that also was thinking about what are some of the more successful or most successful campaigns, and was there elements that we could learn from those?
Yeah, so those are 3 big, really important questions. To the first, which is more,
you have 3 minutes. So
I have 3 minutes. Yes. So the first, which is more of a comment of interest, I will say, please do this work, because we don't have good research at the intersection of race and stigma. Certainly not the kind of research that I'm talking about right now, which is stigma reduction work. And the field needs folks that are knowledgeable in both in anti-racism and anti-racism strategies, with knowledge about substance use and mental illness, to dive in and become stigma reduction researchers with this frame. So I'd love to talk to you more. I think there are so many examples. I'm not going to even try to talk about that one in my 2 minutes. Lisa, I think, remind me just very quick. Oh, she's gone now. Lisa, what was Lisa's the middle question?
Well, she was interested in what were easier targets.
Oh, easier targets. Yeah, from the picture. Yeah.
Right.
So it's interesting. That's such a great question. Like, often in our studies, we try to target those different dimensions with different sort of quote unquote outcome measures. So we expose people to an intervention, and then we ask them and the comparison arm questions about social distance, about discrimination, about labeling, to try to tease that apart. but we tend to find fairly similar patterns. So things that are stigma reducing, reduce stigma across all of those dimensions. Things that are stigma increasing, increase stigma across all of those dimensions in pretty parallel ways. We use feeling thermometers too, lots of different measures to try to get at different elements. But I'll say stigma is, as that picture illustrates, multifaceted and complex. And I think powerful stigma reduction tools will work broadly to reduce the acceptability of discrimination while simultaneously increasing willingness to interact with people with mental illness and substance use disorders. So the right messages can do a lot of work across a lot of different elements for us.
Well, that is a fantastic place to stop. The inspirational note. Thank you so much. I think your talk was amazing, and I think is going to leave a lot of us with, I wrote down the words matter pledge, and then I guess we have to study whether it works.
Let's do it.
Thank you very much. We really appreciate your coming here today, and congratulations on the Essock Award.
Thank you, and thanks again to Susan for being such an inspiration for all this work.